Thank you, Dr. Mims. Great to see you again, and welcome back to CDU.
Good to see you, Dave.
Thank you very much for that, Dr. Carlisle. And now I want to turn things over to Dr. Mims to introduce herself and begin her fascinating discussion. Dr. Mims, thank you.
Okay, great. So for those of you who are not associated with Drew, just to give you that, because I invited a whole bunch of people, and many of the people on the call are from people that are also invited who may not be associated with Drew. I went there for my family medicine residency program, and I have been very excited to be able to be invited to participate in this seminar series, to be able to tell people who are currently involved with the organization and alumni of the organization what my career path has been like and what I've been up to. In addition to that, spending some time focusing in on a topic that's near and dear to my heart, which is brain health. So I hope that the way you have the screen set now, that you have speaker views, so you both see both my slide and my face, that's what you're able to see. So I appreciate your spending this time with me today. And Andre and I were talking, and we said, okay, Andre, why don't you start with this interview part? But I'll begin with some of my background, and if I leave out some pieces, please do kind of jump in. And the reason I wanted to share some of my background is because I wanted you to know that you can come from very humble beginnings, and that does not have to dictate where you are in life and where you go in life. So I was born and raised in Washington, D.C., in an inner city area. We were very poor at the time. I went to public schools and was able to graduate as the salutatorian for junior high school and valedictorian for high school. And after that, I really didn't have funds for college, but was able to receive a full grant to go to George Washington University for undergrad. And this was during the time of affirmative action, which is a good word, not a bad word, mind you. And it was able to provide grants to cover other things like books and supplies and the like. So after I finished there for 4 years, graduating with a bachelor's in zoology, I had the occasion to interview for medical school at Stanford University. And Dave Carlisle and some of his colleagues were part of the interview team that helped us to decide where to go. So they did a interview trip on the East Coast, and I flew up to Philadelphia for my regional interview for medical school. And they said, oh, well, if you come to Stanford, they have lakes and an ocean and horseback riding. So I chose to go to Stanford. Hence, as a medical student, I saw none of that. And I'm sure most people on this phone understand that in graduate education, you don't really get to partake with those things. And Dave Carlisle got me my first job in medical school. I was doing blood gases on prenatal babies in an ICU. So he got me started financially set for medical school. So it's been a long haul, since then. So after I was in medical school, I, like most clinicians, couldn't quite decide where I would truly end up, though it was family medicine when I went in, it went to OBGYN, it went to urology. It came out doing a transitional internship in Oakland at Highland Hospital, which was very much akin to Martin Luther King Jr. Hospital in LA that I ended up for residency. And during my rotating internship, I realized that I could not do obstetrics, that the call, every delivery was 2 people's lives in your hand. That just didn't settle well. But I liked the variety of seeing a large different groups of people, and at the same time, being able to do continuity of care. So I chose to go primary care. So I came down to Drew and did my 2 years of family medicine residency there. And, it's really interesting because of the location. The older people we saw in the hospital were often those who were transferred from a nursing home and really couldn't talk to me. But the older people in our clinic, they were all jazzed up in their clothes, and they would come and sit in that waiting room and socialize with each other and come back when they had a medical visit. But they wanted to get back to that waiting room to socialize. And I said, I like these kind of people. This is kind of like my grandmother, who I really loved a lot. So I decided to do a fellowship in geriatrics at UCLA. And after the first year of the fellowship, I said, well, maybe academia is where I'm headed with my life. And so I decided to do a second year fellowship so that I can have a research component. And research, remember, I came from Stanford. They really wanted us to do research, and that should be the career path for us. But I wasn't a basic science researcher like my sister, who's also in the college, Joy Britton, who's a pathologist, basic science researcher. That's not quite me. I'm a people person, and population-based health was more interesting. So I decided to do a subsequent fellowship after geriatrics 2 years. I did an NIH primary care research fellowship where I got a master's in public health and epidemiology. And that gave me the resource tools to be able to do population-based research in any particular setting. 6 years of training in LA. My husband of 6 years said, that's enough training. It's time to go get a job. So the two of us decided where we wanted to live in the world. Had to be below the Mason-Dixon line, had to be warm. Had to be a city of a couple of million people so I could truly do geriatrics. Had to be a city that had a significant number of African Americans so I could feel very comfortable and not an outsider in my role. And so Atlanta met all of that. So we came here in 1990, and that's where we decided to build the rest of our lives and my career. I started with Kaiser Permanente and built their geriatric program, half-time, and their home care program. I spent half-time also with a clinical practice in my community, 7 minutes from home as a family medicine physician, loving it. But something happened in healthcare in the mid-90s. We began to focus more on quality of care than just the cost of care. And so our organization decided to go to be accredited for quality with an organization called NCQA. And I shifted positions from chief of geriatrics to chief of prevention, health promotion, and research. And now using more of my MPH epidemiology background, helped to lead the team to become NCQA qualified and starting to collect quality measures, which were called HEDIS measures, and putting together interdisciplinary teams to look at what are the barriers in our healthcare system so that we don't have a high percentage of women getting mammograms. The physicians may not know the guidelines, the patients didn't know the benefit, our delivery system may not have been receptive. And so over a series of improvements, we began to address all those types of issues. And so that was an exciting type of role that I had across multiple quality measures at Kaiser. And then later we got into doing an electronic health record. And we end up buying Epic, which is one of the leading standard electronic health records in the nation now. And I was on the team that helped to program a lot of the processes into that system. Still have time doing primary care. And about the middle 2000s, about 2005, I was in my clinic trying to assimilate all of my practice into Epic and had become 4 days a week in primary care, the only geriatrician in primary care. And patients were coming to see me from all over the city because they wanted a geriatrician as their PCP. And I got burned out. And before burnout, healthcare burnout was a term. I realized that I was under a lot of stress. I was working very long hours. And a patient came in to see me who had a cold. And she had waited an hour and a half to see me, but all my patients wait an hour and a half, but they know it and they don't mind waiting. But she wasn't one of my patients. And when she came in the room and I said to her, "So what do you need, a work excuse?" It really off-put her. And I'm like, "Well, you really don't need antibiotics. I'm not gonna do the chest x-ray. You got a cold." And I was processing. And I stepped back from that and stepped out the room and looked and came back in. And I said, "I am really sorry. You did not deserve that. That is not my best. And that's not really how things were supposed to go." But I couldn't put a name on it because we didn't have the term burnout yet, right? But I knew something was wrong in the way I was delivering care. And I knew that the system was not allowing me to close my practice, change my template, or do anything different. And so I had to shift. Now, granted, all of my life up until then was to do part-time geriatrics and have a clinical practice in my community. But in 2007, I realized that this reality that I strove for half of my career, although I'm there, it was not going to be sustainable. So at that point, I decided to leave and go full-time in administration. I became the chief medical officer for Medicaid disease management for the state of Georgia, overseeing a program for 500,000 age, blind, and disabled members in Georgia. And I was working with an interdisciplinary team, doing many of the types of projects for quality improvement I had done at Kaiser Permanente and thoroughly enjoyed that. 2 years later, I moved to a role where I was doing that type of work of quality improvement for all Medicare beneficiaries for the state of Georgia. So I stayed in that role of chief of quality improvement, Medicare quality improvement, for 10 years. And I thoroughly enjoyed it and began to focus in on areas that were key areas that I liked. And I believe a lot in advanced care planning, and maybe we'll have a conversation about that sometime in the future. But the other area is about dementia, and help to work within the state to create our statewide dementia care plan, our advisory board for Alzheimer's and related dementia, our steering committee that I currently sit on today that leads that for the state. And last fall, I was tapped to be on the National Alzheimer's panel for disease research, clinical practice, and care. So I wanted to stop there with my review of my background and see, Andre, was it something that you want to make sure I touched on before we get into a whole discussion about brain health?
I remember you and I had chatted about the words, and maybe this is in your presentation, silver tsunami, and what that meant.
Oh, okay. Well, see, I'm not the only geriatrician on this line, too. I also have one of my mentees, Dr. Margaret Griffin, a geriatrician on the line. And she and I will both kind of tell you, we don't use that term silver tsunami anymore. Right. We at first was something that was descriptive of this large volume of people who were baby boomers turning over the age of 65. And, a graphic artist came up, well, a silver tsunami, that's a big wave, right? But we began to think of that as having negative connotations, like overwhelming and a burden. Whereas if we look at it, there's this large group of people over 65 with all this talent and energy and resources who are now available, who have discretionary time, money, and energy to help support our whole community. And so let's look at some different terms than silver tsunami. So thank you, Andre, for reminding me. I wanted to address that. And so before I go into the brain health, I wanted to see if anybody on the line had any specific questions about my background or career before we go forward.
There's none in the chat. If anyone has a question, please raise your hand or unmute yourself.
Great. So as we go through the slides, I'm going to go casually through them, and I would encourage that there be questions. I show here on the slide that I'm going to be talking about brain health from my perspective. I launched a blog earlier of last year, about topics that are of interest to me. And June, I published this one on brain health that kind of talks about the aspects of this that I think don't get as much play. But as I've been dealing with the field, I think that it's some important topics to kind of focus in on. So let me make sure I can actually change page down. Let's see. 1 second. I apologize for that. This is when you have too much technology, right? Good. Now, I'm not sure how I changed the slide, but hopefully it'll happen each time. Okay. So this is how I want to approach the conversation today. And this is a conversation. Just a brief review of what dementia is, but then talk about how common it is. But then the 3 areas I really want to focus in on, and not really weighing them equally, is what can we do for prevention? What is it like to live with dementia? And how do we support the caregiver? And I hope that this is an interesting enough topic for those of you who have chose to join us today, that if you want to put comments in the chat or questions in the chat, or raise your hand to join the dialogue, that would be very much welcome. And I look at this woman here, and she could have been a person from my practice back at Kaiser in my community. I know what I want to say, I just can't find the words. And this is very much like many of the residents in assisted living where my mother currently lives. This is also like some of the women who live in the subdivision that I'm in. You may say, well, this is very much like the woman who sits on the same pew that I sit in at church. Or maybe it's the person who was in front of you at the grocery store. Or the guy who the bank teller was trying to say, you were just in here and you can't find your bank book. People living with dementia are all over our community right now and will escalate in number. And the reason I wrote this blog was because as a society, we are not appropriately addressing this fact. So if we look at the definition of dementia, so that we're all on the same page, this is a condition that you develop. You're not born with it, you develop it. And sometimes it's a little challenging to diagnose, but it's not explained by something, a little confusion right after having had surgery, or some confusion that happens after you've had a new medication. This is something that you develop and is always there going forward. And it affects different parts of the brain. Now, I had a conversation with one of my mentees earlier this week, and we were talking about brain health from a different subject, from mental health issues. It used to be in our communities, we thought that, oh, if something was wrong with your brain, you were crazy, because the brain was such an enigma to us. But we now know so much about the structure of the brain and how different parts of the brain has different functions. and how there are chemicals within the brain that communicates with other parts of the brain through other chemicals, and understanding chemical imbalances that cause diseases that can be treated, and understanding that damage to certain parts of the brain shows up differently helps us to understand more about dementia. So with dementia, these particular 5 areas of the way the brain expresses itself can be impacted from dementia. So people think about memory. Oh, she can't remember this, or she thinks she's a young child. But dementia can be far-reaching besides that. It could be reasoning and complex tasks like balancing a checkbook and paying the bills and ensuring that all of the necessary arrangements are made. Especially, when you start losing the ability to do those things, that's not memory. That's the ability to figure those out and getting in the right order and make it make sense. Executive functioning. Visual spatial. Okay, we see 2D, we see 3D, we're in our environment, but to be able to understand that this is here versus here and the overlap, how we see and process visually our environment is a part of the brain. And sometimes that can be affected too. Language. I just saw on TV yesterday, on the news, they had this video clip of this woman who was a newscaster, and she was having trouble finding her words. She was actually starting to have a stroke while she was broadcasting. The good thing about it is they showed the whole clip on the news, then explained that this was an example of a stroke starting, and showed how she went to the emergency room and a picture of her. I'm doing fine now. It was a teachable moment, but it was language. It had affected language. That's one way it affects language. It could affect language in other ways, and that you can't quite think of the word. You know the word, but you can't, or you're using the wrong word. Language. And then personality. I may be this pleasant person that I am now, but I've become very aggressive. Or if I start flirting on every man that comes by, that would be a change in my personality. Yes, Joy, my sister, that would be a change in my personality if I did that. Anyway, the thing about dementia, we're talking about 2 areas, at least 2 areas on this list that we permanently have a change, and that impacts your daily life. So it's a little bit more different than some of us think about dementia as just being memory, right? And so when we think about it that way, there are multiple causes for dementia. We all think about Alzheimer's. That one gets a lot of publicity. But dementia vascular, which is from strokes that can hit any particular part of the brain, Lewy bodies, where there are formations in the brain that's disrupting parts of the brain, a combination of more of these together, toxic metabolic, person who is a longtime alcoholic, and I had one of those in my practice. It's kind of sad. He just drank heavy for a very, very long time. He fried his brain, basically. But at the point in time that his wife brought him in, it was irreversible. And he lived a couple more months and had a pleasant death. People with movement disorders like Parkinson's disease, not all of them get dementia, but some do. And you probably heard of traumatic brain injury. We started hearing about that within the football players. And the football players who are getting all of this trauma to their head start showing up with personality changes and aggressive behavior and memory impairment. And we came to know that that was another form of dementia. So these are some of the more common causes of dementia. When I look at them all together along that spectrum of memory, visual, spatial, emotional, along those areas, all of them can have some of those components. So as we begin to not so much talk about, so which one do you have, and which one do you have, and which one do you have? When we begin to talk about adult cognitive disorders as a group, dementia, adult cognitive disorders as a group, and we begin to ask more questions about how are they functioning with their executive functioning? How are they functioning with their memory, their personality, their behavior? We can have more of an understanding of the needs and the resources, regardless of the diagnosis. Currently, our country places a lot of emphasis and resources on getting a diagnosis, and that's important. People need to know if they have dementia so that they can make their plans. But it's not like there's a cure. And once you have dementia, you're still going to live 5, 10 plus years with a gradual decline in those areas of the brain. We in society are focusing millions of dollars and more on getting a diagnosis to try to find a cure, and we're flooding a lot of dollars into the pharmaceutical industry for that. I think if we diverted resources to other aspects of dementia, that might be a good idea. So how common is this dementia? Let's look at that. So back in 2020, we saw data that over 6.1 million people in the United States had dementia. That's a lot of people. You know, when we think about the 2 years of COVID, 2 million people died, right? 6.1 million people are living currently with dementia. And by the next decade, 2030, it's going to be significantly more. You kind of look at this graphic and say, well, you break it up by the 10-year group, 65 to 74, 75 above, 85 above. And you notice that the yellow and purple are getting larger. And that's our baby boomers living longer. And it's more of us who will have dementia going forward. Now, some of you on the call are in training, and some of you are early in your career. Regardless of what healthcare field you go in, except pediatrics, you will be caring for people with dementia. Internal medicine, family medicine, we already know, we got it, right? Ophthalmology, orthopedic surgery, genetics, all of you, everybody's going to be caring for people with dementia. But I'm not talking about it from a clinical practice perspective. That's not what we're talking about today. We're talking about the fact that this is your mother, your aunt, your sister, your spouse, you. What we're coming to understand is that dementia is not evenly distributed, and that more African Americans have dementia compared to Caucasians. You see a similar prevalence in Hispanic and Native Americans and less in Asian. But this is US-based data based on Medicare fee-for-service. I think that what was important about this data when it came out was that prior to this, there was almost a feel within the healthcare community that maybe dementia was not as common in African Americans, or they're just old. No, it's dementia. Things that we were accepting as just old age or the way they act. No, it's dementia. We actually need to know and call it actually what it is. And so those of us in the field are very happy to see the data to more acknowledge that the prevalence is there and that needs to be known and made known to our communities so that we can address it appropriately. So I'm going to shift gears now. But before I shift gears, any questions about the diagnosis or prevalence?
Hi, Dr. Mims. A couple of questions. You may have answered some of them, but one question is, what is the life term of a patient who's been diagnosed with dementia or Alzheimer's?
Great. And so the thing is, we want to go for early diagnosis as possible. Let's say if we get a person at an early stage, they're going to probably live easily another 10, maybe even 15 years. Unfortunately, what has been happening is that people are being diagnosed late. They're at the point that they're unsafe taking care of themselves. They've been living alone. The house is in shambles. They're not at early stage. They're more middle stage at that point when we're first diagnosing them. And so their life expectancy may be 5 years or so. It's much, much less than that. It's not that the time course is any shorter. It's just that we diagnose them a lot later. But suppose we had a ability to find people earlier and diagnose them earlier, and that they can make more plans for their life and their support system at an earlier stage, then they'll be living those easily 10 years. Thank you.
This participant asks, you may have partially answered this question, are there areas impacted in dementia possibly correlated with abnormal changes that can be seen microscopically in the brain, e.g. the cerebellum or Broca's area? Pardon the pronunciation.
Yes, and I wonder if that came from Joy, because she's the micro person.
That did come from Joy.
And actually the answer is yes. Though definitive diagnosis of Alzheimer's is a pathological diagnosis. So that means a person died, you did an autopsy, you cut their brain, and you said, okay, they had this. But we can't wait until then. So we've looked at the patterns of behaviors and memory loss and have been able to develop the syndrome of what dementia is that I've described to you. But in addition to that, in more recent years, we've been able to identify with PET scans that highlight activity in the brain in certain areas before one, dies, and you have to do it as autopsy. And then more recent than that, we have neurochemicals that we can actually obtain through doing lumbar puncture, spinal taps. And the measures of those can help us determine Lewy bodies or Alzheimer's. Now, those particular advancements in diagnosis of PET scans and the neurochemicals from CSF and possibly soon blood tests are not widely available outside of research right now. But if one were part of a brain health center study or went through one of those settings, you will be offered those, and they significantly aid in the diagnosis. And what we notice is that the use of those PET scans and neurochemical imaging and blood tests have helped us to differentiate more commonly that something is not Alzheimer's, but probably vascular. Or, oh, this is actually Lewy bodies, not Alzheimer's. So you get to a more definitive diagnosis that way. But again, because right now we don't have a cure, how are they doing with their executive functioning, their visual spatial, their personality, their mobility? As a clinician, I need to kind of focus there. I'm not saying that isn't important. I'm just saying we need to consider shifting some dollars. Good. Other questions?
No more at this time.
Okay. All right. Prevention of dementia. One slide. There are risk factors for dementia, like it's in your family. You can't control that. As you age, you're more likely to get dementia. You can't control that. But the CDC and Lancet combined have looked at the literature extensively and have determined that there are some modifiable risk factors to you getting dementia. Now, should you start working on these when you're 65? I think you'd have a better chance if you started probably in your 30s and 40s and 50s. And in fact, the NIH, one of their departments, has a focus specifically for African American men in their 30s and 40s to help them understand the benefits of controlling blood pressure at that stage. That will make a big difference on how often they would get the vascular dementia from strokes if their blood pressures control over their lifespan. I already told you about alcohol use. I had a guy who fried his brain. He drank too much. Cigarette smoking, it disrupts the blood flow to the brain. Diabetes, again, the blood flow to the brain, hypertension, strokes. When you say depression, I'm not sure how that relates. Hearing loss, how does that relate? Obesity and physical activity, these are all heavily correlated with dementia. The etiology of how obesity itself causes dementia or hearing loss causes dementia, can't say we kind of work that out. But if we find people who are having trouble hearing and we improve their hearing and have them more socially interactive, we found that that makes a big difference in preventing the onset of dementia. Thoughts or comments about this slide? Only giving this one slide for prevention.
There's a comment from Ms. Kura. Thank you, especially for eloquently stratifying the causes and symptoms of this disease. Unfortunately, I think there's a lot of masking/denial of the disease in communities of color due to the average person's tendency to identify it only as a geriatric issue due to aging of the brain. I believe dementia linked to TBIs, especially among our military/veteran communities.
Wow, Kyra, I'm glad you said that. We think about the football players, we think a little bit about sports, but when you said that about the military, that's real important. You know, that we need to start calling that out and looking and having that being emphasized. We think about PTSD, but what about this cognitive impairment? Thank you for that. Okay. Most of the life of a person with dementia is after the diagnosis. But our community doesn't focus in on this. Do you live in a dementia-friendly certified community? Chances are no, you probably have never even heard of it. But suppose the community that you live in, the people who are in the grocery store, the bank, the library, the corner store, have all had a mini seminar about what dementia is, how it shows up, and how these are normal people. They just have a brain disorder and that they just need some support. Wouldn't that be awesome? That's not happening. For those who get a diagnosis of dementia, there are resources out there. You'll be hard-pressed to find them until you start looking directly. You won't know about them because it's not part of common language. I'd first direct you to the Alzheimer's Association website, number one. You go there, number one, and I've just put a clip on different websites that are part of that. Because once you have a diagnosis, you need to become far more educated on the impact of this in your life. What is it? What should I expect? What is my future? What is the shock of being just diagnosed? How does that change things? Does it affect my life insurance? How will I tell my family? How will I share that diagnosis? Because I'm currently still working. I'm actually the pastor of my church. I'm leading the usher board. I have these roles that I'm currently in, and now I have a diagnosis of dementia that has been a taboo subject in our community. But I still have a lot to give. And I mean, I still had dementia last week when I facilitated that meeting. How does it change our relationships with our daughter, who now thinks that they need to make decisions for us? With our spouse, who now starts thinking about their future, and I'm a dependent or not there? Suppose you live alone and you get that diagnosis of dementia. Should you move? What supports and resources do you need now? Who should be helping you? Regardless, you're going to live the next 5 to 10 years. How do you take care of yourself? Do you have a graduated plan? Getting ready to shift gears again before we get to open it up to more general conversation. But, you know, I hope you've given that serious thought, living with dementia. Half of us on this call, it's going to be our reality. Our community is not prepared. Our family is not prepared. We are not prepared. But as we progress with dementia and we start losing some of our abilities, the caregiver is the person who has to fill in those gaps. So I want to share a little bit more extensive information about the caregiving part. There are many caregivers. We talked about 6.1 million people with dementia. There's 15 million unpaid caregivers. The unpaid caregivers is you all on the phone. It's not the ones who are, working in the nursing home or working in assisted care. We're talking about family members. And I'll get to what those tasks and roles are shortly. But I want to emphasize that we are not alone as caregivers for people with dementia. It's a lot of us. And we're individually trying to figure out the system. We're individually trying to find resources and solve problems. We're individually doing this because who has seen the commercial that says, "Are you a caregiver? Call us. This is what you do." Okay. Has that made the front page of the news? Okay. So 15 million caregivers are each doing this one at a time. And it ends up causing stress, emotional stress, and physical stress. We step in this role as caregiver because something needs to happen. Oh, they need a ride to the doctor's office. Oh, they're getting ready to get discharged. They need to have the medicine picked up. Oh, well, we just heard they got out the hospital and need some meals made. But that's at one point in time. But then as you keep adding those on over time, that time to do those things and the energy to do those things that you're doing comes from somewhere. And the burden that you end up having causes emotional stress and physical stress that's not being acknowledged. Look at this data. I wanted to share this. So we're talking about caregiving for dementia, which is the purple. The green is other people you do caregiving for. So these are the caregiving tasks. Dealing with incontinence. The person can't hold their bowel or bladder. You're changing diapers. A third of the people caring for someone with dementia is changing diapers. They may be the principal at the school, but at home, they're changing diapers in the middle of the night. Do you think that has some emotional stress? Making sure the person can get safely to and from the toilet. Making sure that the food not is just on the plate, but actually in their mouth. Assisting to be sure that they did wash their back and the bottom of the feet and that they were safe and not falling in the shower. Putting on clothes, appropriately seasoned clothes. I don't care if it doesn't match, doesn't matter, but appropriate for them. And getting in and out of bed and chairs. So you say, well, this is a lot of work. Yeah. Caregivers do these things when people with dementia get to advanced stage beyond just memory, and they start having mobility and problems and losses of other issues. They need help with these things. Now, if they only need help with getting dressed and taking a shower, they can still live at home alone. You just send somebody in there at the beginning of the day and the end of the day to help out. But as dementia progresses and you start having other problems, this becomes more 24-hour care. The thing about dementia is you start functioning here, but you all go down to functioning here 100% of the time. So when you start caregiving at this level, or maybe here, or you might find yourself here, we don't realize that the trajectory is 100% here. We may be in the crisis of the moment with the bedwetting or the hollering or trying to get mom to eat, but 100% will go to total care. 100% will go to total care unless they die earlier for something else. And if we're the caregiver now, we have to begin to plan for the need for additional resources and supports over time. But what about those of us who are still working? The data has shown that as a caregiver, you are more likely, almost 60% of the time, you went in late or had to take off early. You know it. Yeah. A doctor's visit, that fall, or, oh, something happened. You cut back your hours. You're no longer contributing to your pension. You took a leave of absence. You just stopped working because you couldn't do it all. But then this is the period of time, many of us as caregivers between 35 and 65, we're trying to save for our own retirement. And some retired early. This is a significant impact on a caregiver. So on my last slide here, take care of yourself. Give yourself permission to ask for help. It's 15,000 of us who are caregivers. 15 million of us are caregivers. Resources are out there. We have to search to find them. We need to ask for help. We need to have family conferences. We need to share the burden with everyone else. We need to plan for our future because this is the trajectory that we know will happen. So the reason I, gave this talk today is because I will take any audience that I can shake and wake up. We're at a crisis here, people. We're at a crisis. We have 6.1 million people with dementia, and it's escalating every day. And our system is set up to try to get you a diagnosis, go to a memory care center, try to get a drug that's not going to cure you. But let's spend a lot of money on those drugs. But when it comes to where's respite care, where's someone to provide the meals, where's someone to do community chores, where's someone to make sure that my loved one is safe going to the doctor's visit so I don't have to take off, where's the EAP benefit at work so that it's okay that I take care of my mom, but I'm not going to get written up because I'm not as productive, because it's understood. Where I want to raise the issue about these gaps we have in society that is not there to help support us. So with that, I'm going to stop talking. I have references and can make the slides available. But I want to, have more of a dialogue. So Andre, do we have anything in the chat?
We do, a couple of questions. You touched on this already, but are there any support groups or online communities for caregivers that you'd recommend?
Start with the Alzheimer's Association. And there are caregiver classes too. The caregiver classes can be on-site in a community center. They can be weeks long. They can be virtual. There can be different ways that it's done. Many of those are free. Some of them have a cost. I highly recommend it. There are books. The 36-hour day is the gold standard on understanding what it's like to have a loved one with dementia. It's a small paperback book that we highly recommend. And Margaret, I'm gonna ask you for references too. Another book for caregiving is one called The Doctor Is In, by one of our colleagues, Dr. Cheryl Woodson. She's a geriatrician who cared for her mother with dementia for 15 years. The Doctor Is In. Margaret, you want to offer any thoughts here?
Oh, I think your recommendations are excellent. And to get started, that's most reasonable in terms of the understanding. One question I do have is bringing up the point about advanced directives. I'm retired now, but one of my frustrations was people who have been diagnosed with dementia, and then they came in on an acute situation and people had to make decisions about interventions that probably were not appropriate, but legally binding. So any comments about that?
Thank you. I could have paid you to set that one up, but you did it anyway. So that's one of the most important reasons for the early diagnosis. When a person has all of their faculties about them as much as they have at a given point, when they can make their wishes known. So let's say, for instance, I'll give you an example. My mother's 84 years old, and I think I've been talking to her about advanced care planning for 20, 30 years. We have all her stuff written down. She knows what she wants. She does not want to be resuscitated. She does not want a prolonged life. She doesn't want any heroics. She said, Adrienne, you're going to be the person to speak on my behalf. And if you're not there, Joy is going to be able to say this. The important thing is, what people don't get with advanced directives is, it's not up to the person speaking to make a decision. It's up to the person speaking to relay what that patient wanted. You're just speaking your mouth with their words. And we need to get those words from them early. Thank you, Margaret.
Yeah, written on paper.
Yes, written on paper. Anything else in there, Andre, before we close?
Yes.
I just have 2 minutes.
Yes, one more question and comment. This is from Brenda Hernandez. First off, thank you for your presentation. I lived through a loved one's Alzheimer's journey, as well as seeing how stressful it was for the caregiver. This information is very important. And again, I thank you for your dedication to brain health. My question is, do you think there will ever be a cure for dementia or Alzheimer's? How close do you think we are?
It's a very good question. There is a lot of research, a lot of research in many aspects of theories around the causes of Alzheimer's that are being done. And if we find that and it makes a difference, great. But 6 million people right now have it, and not all of it's Alzheimer's. And the cause for Alzheimer's versus Lewy body versus traumatic brain injury versus vascular dementia are all different. You may say, oh, I'm glad I didn't get Alzheimer's, but you got vascular dementia. Okay, so my focus is not really so much on that. And I respect that that's where people are very interested in. We are, as a nation, putting all our resources that way. But as I wanted to do the presentation today, let us care for the caregiver and let's care for the people who are living with dementia. Thank you.
Thank you, Dr. Mims. A round of applause. Thank you all for joining us. Thank you again for this really brilliant presentation. I think all of us took a lot away from it. And we will post this video to our YouTube page and for folks to reference it later if they want to look at it again. So again, on behalf of CDU and Dr. Carlisle and faculty, staff, and students, thank you, Dr. Mims.
Thank you. Bye-bye.
Have a good day.